It's our pleasure to welcome Dr. William McGaghie here from the Department of Medical Education, Preventive Medicine from Northwestern University to present our keynote lecture. Dr. McGaghie's medical education scholarship is wide-ranging. It includes personal and curriculum evaluation, research methods, clinical skill acquisition, the science of expertise, and especially, as you'll hear today, simulation-based mastery learning. Dr. McGaghie has an incredible expected track record of education scholarship and national recognition for his work. And he asked me to keep this brief so he could spend the time enriching our minds. So with that, I'll hand it over to Dr. McGaghie.
Thank you so much. Can everybody hear me?
Yes.
Okay, great. I always begin my talks with this. I say it is with great regret. Great regret that I have no financial stake in what I'm about to talk about. So you need to have that assurance. What I'm going to begin with, I'm going to show you a video. I'm going to show you a video of an encounter. It's a patient in a hospital bed, spouses right nearby, kids in the background, talking to a nurse. And they're asking, the patient is about to undergo a procedure. And he's asking about the doctor who's going to do the procedure, the doctor friends, asking the nurse, and the doctor comes in, they have an encounter, and the thing is over. But I want you to focus on the doctor and the nurse's assessment of the doctor and how this proceeds. All right, listen carefully.
Have you ever worked with Dr. Francis? Oh yeah, he's okay.
Just okay?
Guess who just got reinstated?
Yeah.
Yeah, me too. Don't worry about it. We'll figure it out. I'll see you in there.
Just okay is not okay.
Just okay is not okay. Think about your own experience. Most of you are pretty young. How many of you have experienced or know about a Dr. Francis? We've all seen people like this. Their reservations? Oh my God. I want you to dwell, and we're going to come back to the Dr. Francis illustration. This is not unique. I don't mean to pick on this one person, but it represents a condition that we see all too frequently in clinical medicine. Here's what I'd like to accomplish in this talk. Spend very briefly to talk a little bit about the history of clinical education as we know it today. What are its origins, where it come from? How do we find ourselves in the current state of affairs? Because it's important for us to reflect from time to time, not only on where we are, but how we got. I will give you a very concrete example of a mastery learning project. It's very different. It's designed to prevent the impression of your Dr. Francis. Those of you in the audience here present have a copy of a one page from the journal article I'll be focusing on. Those who are online will have to bear with us and rely on the talk to do it. Third, I'll address some issues about the road to improvement, how we think we can do better. Then we'll leave a little time for Q&A. So that's the roadmap. Here's what I'd like you to see. Take a look. Sir William Osler published a collection of his essays in a book called KEYNOTE. It was published in 1932. One chapter in that book is titled "The Hospital as a College." That chapter is a summary of the talk he gave to the New York Academy of Medicine in 1903. The talk was inspired by the work of Oliver Wendell Holmes in an essay that was published in 1876. That chapter lays out the logic as well as the structure of the clinical clerkship as we know it. It's a blueprint for clinical education, bedside teaching, see enough patients, you'll be a great doctor, the wisdom of the senior physicians imparting knowledge to the junior physicians, you get the picture. That blueprint describes the condition of most of clinical education as we know it today. Now, my point is that even today, we're educating 21st century physicians using 19th century thinking and technology. 21st century doctors, 19th century thinking and technology. Despite all the advances we have, or science of expertise, how to improve expertise among trainees. I'm going to give you an example, a very sterile example with some data. We're going to move to some data. I'll tell you a story. In about 2010, the journal Academic Medicine decided they wanted to publish a special issue on the topic of comparative effectiveness research. That was spawned by the rise of the Clinical and Translational Science Institutes program from the National Institutes of Health here in the United States, where these CTSA institutes were formed or established at a wide variety of medical schools. And the principle that drove the establishment of the CTSAs, Clinical Translational Science Institute, was to move or accelerate the translation of data from bench to bedside. It tried to do everything it possibly could to accelerate the movement of basic data to bedside care. So at that time, the editors of the journal Academic Medicine decided to publish a special issue on comparative effectiveness research. And it was assumed that most of the studies would address drugs, devices, surgeries, comparative effectiveness. You get the picture. The editor of that special issue was a man named Harold Pincus. Harold is a psychiatrist at Columbia University in those days. This is about 12 years ago. Harold was a friend, so I called him up and said, Harold, would you be interested in receiving a report that would look at the comparative effectiveness of traditional bedside clinical education in contrast with simulation-based medical education with deliberate practice toward the goal of clinical skill acquisition? Clear? Traditional education versus simulation-based medical education with deliberate practice toward the goal of clinical skill acquisition. Harold hemmed and hawed for a minute. He was cornered, but he said, sure, go ahead. If your team can pull it both together, we'll be willing to entertain the paper. So we assembled our team. We did a very thorough, systematic review of the existing literature at that time. Remember, this is 10 years ago. With the reference libraries, we assembled the studies. We found about 14 studies that did those very direct head-to-head comparison involving about 700 medical learners. Here's the result. Here's the summary table from that book. 14 studies, about 700 medical learners. On the right-hand side, the far right-hand column favors simulation medical education with deliberate practice. On the left-hand column favors traditional clinical education. They are pretty convincing. All 14 studies, without exception, favor systematic simulation-based medical education with deliberate practice compared to traditional Oslerian education without exception. Not one of the error bars touches the null value. See for yourself. Is there a statistician in the room? Somebody. There's got to be a statistician. Come on, fess up.
No, but I slept at a
Damn.
6 last night.
All right. You slept last night. Okay. That's it. Calculated what's called the Cohen's d coefficient. Can anybody give us an interpretation of what Cohen's d coefficient of 2 means? Have you ever seen that? All right, I'll tell you. I've been doing research for over 45 years like this. Never have I seen a d coefficient that high. A large d is usually about 0.4. This is 2.0. It's unprecedented. So the data are not only consistent, they're utterly convincing. No comparison. There is a comparison, but the data are overwhelming. Recall, this was published in 2011, and we've come a long way since then. So this is simulation-based medical education with deliberate practice. We've gone beyond that, and I'd like to show you how and why. Now we talk about the idea of what's called mastery learning for skill acquisition or for clinical competence acquisition. The principle underlying mastery learning is the idea of excellence for all. Why settle for anything but the best from all of the people that we're privileged to educate, to train, to become expert clinicians? excellence for all, mastery learning. And here's an example. Those of you in the room have this sheet in front of them. People online have to read the fine print if they can carefully. Take a look at the title of this paper published last year in the journal ATS Scholar, brand new journal in pulmonary critical care medicine. The first author on this report is Clara Schradel, my colleague, protege of mine, it turns out. Clara is an attending physician in the medical intensive care unit at Northwestern Memorial Hospital, about 8 miles from here. And you see the rest of the team. Clara got interested in educating residents to manage patients on ventilators. The title of the talk, the title of the paper is a little bit off because it should say resident skill managing patients on mechanical ventilators, but we can't change it now. Clara told me a number of stories, in fact, in her experience, where a green resident, young resident, would show up in the ICU for his or her first rotation, be oriented by the fellow, say, here's Mrs. Spotsgato, she's on a ventilator, she's right at death's door, if she dies, it's your fault, goodbye. Happens all the time, you know that. You've done rotating internships, maybe it happened to you. What does a resident do under those circumstances? Go find a nurse, right? Help me, what do I do? I'm gonna keep this person alive. Somehow people muddle through it. Well, Clara said we gotta do that. So if you look at those of you who are present and those of you who are with us, under the objective of this report in the abstract, it reads, and I'll read it for those who are not present. The purpose of this study was to determine whether simulation-based mastery learning, as compared with traditional training, is an effective strategy for teaching residents the skills necessary to manage patients requiring mechanical ventilation. So it's a comparative effectiveness study. Traditional education versus traditional education plus a dose of simulation-based mastery learning about ventilator patient management. Pretty straightforward, very simple comparative study done at the medical intensive care unit at Northwestern over a period of about 18 months. The successive people who rotated through. Here's the structure of the study. And you can look this up on your own. It's available through PubMed. 2 arms. These are residents chiefly in internal medicine. There are a few emergency medicine physicians, a few in anesthesia, so forth. But a cohort study, not a randomized trial, but it's big enough anyway. So you see on the left-hand side, or on the right-hand side, these are medical intensive care unit residents. They receive traditional training. What's traditional training? Well, it's 4 hours of didactic critical care education, basically lectures from a fellow, daily rounds, and informal teaching sessions and seeing patients in the clinic. That's it. That's the curriculum. The curriculum is patients. We all know that. Okay. So that's what the traditionally trained residents in that arm got. On the left-hand side, you see the intervention arm, where the residents first receive a pretest of all things. What do you know about patient management? Do you know anything about the equipment, how to manage dials, how to read the values, and so on and so forth? They got a pretest. Turns out the pretest is a key feature of the education intervention. It's not just a test. People take the test, they get feedback, and say, "Holy man, I've got a lot to learn. I never realized that I was unaware of this." After the pretest, they got feedback. So they had their traditional training just like the other group, but they also got a little bit of didactics, but they had deliberate practice with feedback on simulators using a number of case scenarios involving patient care management with feedback from an attending or fellow. Practice, feedback, improvement, so forth. The addition to the traditional curriculum was about an hour and a half. Hour and a half. Then everybody got the same post-test. 47-item checklist, simulated management of patients with normal, obstructed, and other kinds of pulmonary problems. For the people, and they had, when the traditionally trained folks took the post-test, they were done. For the folks in the mastery arm, there was a minimum passing standard. If you passed the first time you took the test, great, move on. If you didn't pass, it's all right. Give you a little more instruction, a little more practice, a little more effort until you reach minimum passing standard. So it doesn't end at when the time is concluded. It ends when you reach the mastery goal. Right? And here's some background characteristics of the residents. Whoops. We won't focus on that. Basically, it means the groups are similar. Here's what I want you to look at. Here's the outcomes of Clara's study. The left-hand column are the pretest data from the people in the intervention group. They'd never worked with a ventilator patient. They'd never seen it. They'd never had this kind of a clinical challenge. What do you see? The data look, as many of my friends say, the data look like the dog's breakfast, right? They're all over the map, as you would expect. They're inexperienced. They don't know how to manage these patients, but they got feedback. Look at the mean. The average score on the checklist, 0 to 100, 51%. Standard deviation, 17. So not only is the central tendencies low, there's a lot of variation on the data, just as you would expect. Now, after the traditional intervention plus the mastery learning intervention, look at the second column. A whole bunch of the people passed, not everybody. The average score in the training group rose to 86%, standard deviation shrunk to 7.6. The story's not over. This is the you're okay, he's okay group. Under most circumstances, the study would end. Again, there's a statistically significant difference. Why not? We can stop. Intervention work, that's not good. Not in mastery learning. Those who didn't pass the test the first time got more training. We don't use the word remediation. We never use the word failure. You just need more time. So you practice some more. At the end of the day, look at the third column. Everybody passed the test. 47 item checklist, rigorously developed, approved by all the attendees, so on and so forth. What it doesn't show you is that the residents felt great about themselves. Why? Because they knew they're better doctors. They nailed it. They know how to manage patients. They aren't scared of death. The traditionally trained group, you see the results. Looks a lot like the pretest data from the mastery trained group. Mean of 60, standard deviation of 13. Look at the mean and standard deviation at the end of the day for the mastery trained group. Everybody passed the minimum passing standard, which, by the way, was set by a panel of experts. 92%, the standard deviation shrinks. That's excellence for all. That's our goal in mastery learning. We can do that. I'm ahead of myself. Excuse me. Just a second.
Professor McGaghie.
Yeah.
Would you prefer to save questions for the end or?
At the end, yeah.
Okay.
Let's go behind the curtain for a minute. Let's look at the traditionally trained group, what you don't see in figures. Among the traditionally trained residents in this study, these are all very bright, hardworking, intelligent people. They want to be great doctors. Less than 25% at the end of their rotation would report an acceptable area of resistance for ventilator patient. Less than 25% would figure out that is calculated ventilator adjustments for ARDS patients. That's high school algebra. They couldn't do it. Why? Smart? Why? Because they're not trained. You don't educate them in a systematic, thoughtful way. It's not unique to this study. We've done other work, for example, where we educated internal medicine residents to do something as simple as an LP. 4-hour curriculum, mastery standards in the laboratory. We brought them all to very, very high standards. We compared them. These are Northwestern trainings. We compared them to neurology residents from 3 neurology programs here in Chicago, all very bright people, great schools. to do the same skill and be evaluated in a controlled environment among, these are second, third, and fourth year neurology residents doing an LP. They've done hundreds on real patients in the clinic. Among the neurology residents, less than half could identify the correct anatomical landmark to do the stick. They didn't know where to put the needle. Less than 40% could report the laboratory test to do on the CSF. That's traditional education. Those are two, we could report many. Traditional education, that's important. Central venous CDC skills. We did a nationwide mastery. We've done mastery learning studies for putting in central lines at Northwestern. We can train internal medicine residents to mastery standards, flawless performance in about 5-6 hours, two, maybe 3 sessions. We took the program nationwide, went to VAs across the United States to do a train-the-trainer study to educate attending physicians at 50 VAs, about 102 attending physicians who have been training residents and fellows to do central lines for years. Train-the-trainer study, the first step in a mastery program for anybody, for attendings or residents, anybody else, is to give them a pre-test. We gave the attending physicians at these 50 VAs, all of whom, virtually all of the attendings had academic appointments at major medical universities or institutions. 18% passed the test for IgA insertions. 23% passed for supply. This is published in Critical Care Medicine a few years ago. I'll send you the citations. Are these bad people? Of course not. Why are their scores so low? Because they were never trained in a thoughtful, systematic way. They've been training other residents, the attendings, for years and years, passing down bad habits from generation to generation. That's not. And we think that one approach, that is mastery learning, is a good way to go. So here's what we think is a road to improvement. Mastery learning with deliberate practice. Well, what does this involve? If you're interested in clinical skill acquisition, in your case, maybe it's contour. What does it take? What does mastery learning involve? Well, it means you educate people in a controlled laboratory setting to a high standard before you let them work on patients. And it goes hand in glove with the idea of deliberate practice. Here's what mastery learning involves. First, baseline or diagnostic testing, which is a key feature of the education intervention. We never use assessment data as a weapon. We always use assessment data as a tool. Got to establish a baseline. I can't help you improve unless I know where you are and what it takes to help you improve. We can give you feedback and make you an expert. It starts with a baseline test. Moves to we have clear learning objectives regarding the skill of importance. Ordered by difficulty. We engage people in education activities, usually deliberate practice of the skill that we want them to acquire. Focused on the objectives with a minimum passing standard for each unit. Minimum passing standards, we have engaging very straightforward ways to use panels of experts to establish those minimum passing standards. It's not something that's done on the seat of the pants. People engage in formative testing with feedback until they master the unit, and they advance if their performance meets or exceeds the minimum passing standard. If not, that's okay. You're smart. You know you want to do well. You continue with your practice or study until the minimum passing standard is reached. And here's the key. We don't care how much time it takes. All we care about is that you acquire that skill, sometimes to an almost flawless route. Guess what? The trainees love it. Why? Because they know they're better doctors. They nail the skill. Anybody who's been an athlete, runner, tennis player, sort of thing, you understand what it takes to become a master. So how does this fit with the idea of deliberate practice? Well, this is based on the work of elite honors. Here are the features. Need highly motivated learners with good concentration. Sounds like the residents and fellows we're privileged to work with, doesn't it? Everybody wants to be a great doctor. People engage in a well-defined learning objective. It overlaps a lot with the idea of mastery learning. An appropriate level of difficulty, not too hard, not too easy. Focused, repetitive practice that leads to precise measurements. Aha! That yield informative feedback. Everybody wants feedback. How do I get better? Well, we can not only give you feedback, we give you good feedback based on reliable data about how you can become better. Not just, oh, you're a good person, you did well on that case, or see you next week. It's very specific. Where trainees also monitor their behavior, and they engage in more deliberate practice and continue with evaluation to reach a mastery standard and then advance to the next task. The goal is always constant improvement. You operate in a human system, you're always going to have variation. People will slip, people get rusty. The idea is in the mastery environment, you practice in a controlled setting until you achieve the goal. You can do it, people can do it. If you let them know what the goal is, what you want them to acquire, here's how to do it, I'm going to help you become great. Nobody's going to say no. So long as the environment is psychologically safe. That's important. Now, here's some other pearls about deliberate practice. Again, this is based on the work of, sadly, the late Anders Ericsson. What is deliberate practice? Again, in a controlled setting. Individual training activities, especially designed by a coach. It's not an attending who looks at you, wanders around and rounds and stuff. It's a coach who wants to help you get better doing this task. To improve specific aspects of a performance through repetition and successive refinement. Individuals have to monitor their training and engage in with concentration, which is effortful. We know that deliberate practice is working toward the goal of clinical skill acquisition if the trainee is sweating. That's what we look for in the lab. If the person is working hard, ACLS, LPs, ventilators. I'll give you an example of Breaking Bad News. We do that too. The trainee has to work hard. It's not easy. It's not easy to become a doctor. It's not easy to maintain your skills. You have to work hard. And here's an illustration. You want to be an expert? Here's what it takes. Got to have a clear goal. Got to set up the conditions under which that goal, practice sessions can be set up to reach that goal. And you gradually improve it to reach a specific aspect of the mastery goal that we set up from minimum passing standard. If you have the time, read Denton Cooley's autobiography. He goes on a great length about what it took to become a great surgeon. He describes, without knowing it, key features of a deliberate practice program. Deliberate practice. Take a look at this. Here's a deliberate practice session in action. Trainee or coach on the right, trainee on the left. You can tell this is old. They're putting in central line, so you don't see an ultrasound here, so you know it's an old cell. But you get the picture anyway. Coach on the right, trainee on the left. Trainee is practicing fully gown and gloves, sterile environment, the whole shebang. Look at that picture. Ask yourself, who's the most important person in the room? Who's the most important person in the room? Take a look. Tell me.
Patient.
No, it's not the patient. If you are in the clinic, if you're in the hospital, yes, because the hospital is there for patient care. The patient is the most important person in the room in the hospital clinical setting. This is a simulation lab. Who's the most important person? Who's the focus of the attention? The trainee. All the resources in the room, all the time, is focused on the trainee, in this case, her acquisition of vital clinical skill. Tables are switched. Priorities are completely different. The goal is to see to it that when that person leaves the room, she is a better doctor than she walked in. Pretty simple. Totally different from the bedside teaching that William Osler promulgated 120 years ago. Very different. All right. I gave you examples of ventilator patient management. I talked about LPs, showed you central lines. Here are a set of other skills, other clinical entities, other clinical skill sets that we have used mastery learning to help residents, attendings, and others acquire the mastery standards. So it's not just surgeries, not just sticking in tubes, not just doing LPs, not just putting in central lines. Breaking bad news. Managing patients with status epilepticus. A lot of clinical thinking went. In fact, in the editorial that was written about Clara Schradel's ventilator patient management study said, this is important because there's a lot that's captured in the study that doesn't appear on the surface, thinking, the judgment, and whatnot, that isn't revealed by the graph, but is embedded in the checklist. A wide array of, this is only the beginning of what we've done at Northwestern so far. Educating young doctors to mastery standards, sometimes attendings as well. And oh, by the way, they feel great about themselves. The affective consequences of mastery learning are huge. We just beginning to study. Here's an example. This is a training session. Medical student, fourth-year medical student, in the middle, in the center of the picture, working with a standardized patient, engaging in practice activities involving breaking bad news. I'm sorry you had a very bad cancer. I had over breakfast this morning with a number of people. It was acknowledged, who are they? Who was I talking about at breakfast? Like, okay, we were talking about how difficult it is, even for oncologists, we do this all the time, to work not only with patients, but their families, to break this bad news. Almost never are people taught in a systematic way how to do this. My colleague, Julia Vermillion, is doing mastery training, and her colleague, Gordon Wood, are doing mastery learning with a vital clinical skill that is often never touched in training. You never get it in bedside teaching. We're changing it. And Julie's work was published in Academic Medicine 2 years ago, at the height of the pandemic. Look it up. It's a great paper. Academic Medicine, 2020, Julie Vermillion. All right. You want to be an expert in any field? About 15 years ago, I was privileged to dine with Yo-Yo. I think this is Brown. Somebody better more quickly. Yo-Yo Ma's virtuosity is not an accident. He practices in the studio 6 hours a day. So when you hear him perform, you see him perform, if you're privileged, listen to his music, it's not an accident. His God-given talents, but his talents are shaped by people. Want to be an expert? It's not something that's what you strive. Want to be an expert? Work hard. You have to shoot for that. Okay, when's the last time you came to a medical conference? Thought that would liven you up. Okay, that said, I'll stop. Questions you got?